All right. Okay, so we carry on with the oxygen cascade. And I showed you that as you move from atmosphere to tissue and mitochondria, there's a drop. Now, if you measure oxygen with a transcutaneous oximeter, that is the extent that you are measuring. So you're measuring down to the level of the arterioles. We can extrapolate upstream. In other words, if that's normal, we can say, well, what has happened prior to that? The atmosphere, the breathing, the lungs, the initial perfusion from the lungs, that's normal. But we cannot say and extrapolate downstream. Does that make sense to everyone? We cannot assume that the oxygen bound to hemoglobin is going to get into your big toe. It might be amputated, okay? So we use transcutaneous oximetry to get further down the cascade so that we can now measure in tissue how much oxygen actually gets into the organ. And in fact, there are assessments that even measure it at cytochrome AA3 in the mitochondria. We can do that, but this is good enough for the work that we want to do. Okay. Now, from a perfusion side, as I mentioned, you can use duplex Doppler, acoustic Doppler, or laser Doppler, which is rarely used nowadays, but it is available. An acoustic Doppler, you usually listen to arteries and arterial flow, and it is divided into triphasic, biphasic, and monophasic. Triphasic sounds like this. And that bounce back of the third phase means that the arteries are still resilient, they're still elastic, and it's actually a pushback from the cardiac valve. So that's a good sign. Blood vessels are about 80% open. Biphasic is, you don't have that bounce back. It's about 50% open. And monophasic is, it can get through the stenosis, but there is a significant stricture and typically less than 20% patency. So that's what Doppler can tell us. And by extension, what we can do is compare the arm to typically the foot by doing what we call the ankle brachial index. Brachium is Latin for arm. So we do an ultrasound blood pressure of the arm, and we do an ultrasound blood pressure of the foot. And we compare those. And why I'm emphasizing ultrasound is you shouldn't use a stethoscope for the arm and an ultrasound for the foot. You want to compare apples to apples. And then you derive a ratio, and this ratio then guides you on the potential use for compression garments and the like. The next is magnetic resonance angiography, or CT, which can give you, by indicating where hemoglobin is, which of the blood vessels are patent in the area of interest. But what we're going to be talking about is transcutaneous oximetry. And I'm going to tell you where that fits in. Now, its origins actually lies in pediatrics and specifically neonatology. Why? Because the neonate's skin is so thin that if you put a transcutaneous probe on the skin, it measures umbilical vein PO2. And as those of you in obstetrics obviously know, umbilical vein values are what you would find as an arterial adult value. So umbilical vein and transcutaneous oximetry values are virtually identical, and I'll show you that in a moment. In adults, we can use it in two settings. We can use it as an indication of central oxygenation. For instance, in an ICU, you measure the skin, and if a patient decompensates, the first thing that happens is blood is withdrawn from the skin, and you get an early warning sign that this patient's going to crash. Secondly, you can use it as part of sleep studies, polysomnograms. What we most typically do, though, is we look at the periphery. So we look at claudication, we look at peripheral vascular disease, we look at wound hypoxia, and of course, we can use that to determine likely successful amputation, which you can't always determine by merely looking at the blood vessels. And then, of course, from our side, looking at HPO, when to start and when to stop. Now, this graph is actually the comparison between an umbilical vein in a neonate and the transcutaneous oximetry. And the reason why these graphs are apart is they had to artificially split the plotter, because if it had run concurrently, it would have been one single line. So you can see beat by beat, moment by moment, those measurements are the same. And that is very valuable because it's a continuous measurement. So you can measure that for hours. You rotate it every 8 hours or so, and you would have continuous assessment. And it's excellent for titrating oxygenation. Now, on the adult, it's not the case. If you compare transcutaneous oximetry to a blood gas, you get the scatter plot. Why is that? Because adult skin is thicker, it's metabolically active, it's also vascularly reactive, so it can constrict or it can dilate in response to a variety of stimuli. But for our purposes, we want to know what this tissue is doing. So we want to know what those values are, but they aren't necessarily the equivalent of a blood gas. They are now a tissue oxygen level. It's necessary to know something of the vasculature because you want to determine where you put your probes, but you also need to realize that there can be what we call islands of ischemia. In other words, you can measure one part of a limb and it's normal, and you move it to the other side and it's abnormal because that particular blood vessel is cut off, which is why we don't do single values on limbs, we do mapping. We want to make sure that what we have is a summary for the whole limb, not just for the one site that we chose. Now, I'm going to show you one of my videos, tutorials on transcutaneous oximetry. So you'll have a chance to actually see the apparatus, how we prepare it, and it's 8 minutes well spent because it'll give you a good sense of what's really involved.
Transcutaneous oximetry is a relatively simple examination which is non-invasive and an essential part of selecting patients for HBO, determining whether or not they have healing potential and are candidates for receiving HBO, as well as determining whether the treatment has been successful and can be discontinued or needs to be modified. It consists of a peripheral series of equipment which include a razor to remove any excess hair that will break the airtight seal or gas-tight seal, then sticky tape to remove any dead cells of the stratum corneum, an alcohol swab to remove glue and any other oily substances, a ringlet that is applied to the skin to provide the gas-tight seal with the electrode, and a solution that bathes the electrode and brings it in contact with the skin and allows gas to then move outside of the skin into the electrode for measurement. The selection of the site is very important. It's usually the lower limb, and diabetic patients are of the most common referrals. The sites that are selected are very important. They should typically be concave rather than convex, and one should avoid bony areas as well as areas with major arteries. So for instance, the dorsalis pedis area and the tibialis posterior area are not ideal. Neither is the bony area over the pretibial surface. What we choose when doing assessments on the foot, when possible, is usually the first and fourth web space, sometimes slightly higher, and avoiding the arteries, and the posterior gastrocnemius area, which is where below the knee amputations would be performed. Once the areas have been identified where the electrodes are going to be placed, the area is shaved, then sticky tape is applied, usually up to about 10 times when the tape no longer becomes opaque because of the removal of dead cells, and be very careful not to injure the skin. Then it is cleansed with an alcohol swab to remove the glue or any oily remnants or creams, and then the ringlet is applied. Now, very importantly, the adhesive surface of the ringlet must not be touched, and only use the tab as well as the ringlet surface or the ringlet protrusion to hold onto the ringlet. It is then applied and sealed very gently over the skin. 1 or 2 drops of potassium chloride are then added to this ringlet, after which the electrode is attached. The electrode is at this stage been calibrated, and we'll show you the calibration sequence shortly. It is turned anti-clockwise until it clicks, and then clockwise until it locks. The value should be 159 at sea level, and would vary, of course, with altitude. Upon attaching it to the patient, you will notice that the monitor reading immediately begins to fall. This is an appropriate sign and an indication that there is metabolic activity in the skin under the electrode. So this is an expected response, and it may vary from patient to patient, and of course the metabolic activity of the skin underlying the electrode. At a certain point, there may be a reversal of the downward trend, and the higher the number in which this occurs, the better the prognosis generally is. You will see a timer on the left-hand side, which is a remnant of the time that these devices were used in neonates, and it was to remind people to remove and circulate the electrode to another site after a period of a maximum of 8 hours. So in this case, the value is dropping down to approximately 58 millimeters of mercury. Once the patient has stabilized after a period of 10 to 15 minutes, they are then placed on oxygen. By this time, they will already have been made comfortable in a standardized position, and the oxygen will then be applied. We want to provide the highest possible PO2, and therefore we use two choices, of which the most available one is usually the non-rebreather mask. It's pre-filled so that the patient never feels as if they will suffocate. It is secured over the nose, and the metal strip is used to make sure that it seals over the bridge of the nose as well. Now we start recording after every minute that elapses from the point of oxygen administration up to 5 minutes, and then at 10 minutes. So as the oxygen perfuses into the area where the sensor is located, we anticipate a gradual rise. Depending on how quickly this happens, gives us an indication of the underlying pathology, as discussed in the previous lecture. Here we can already see that there is a rapid increase, and the arrow now shows the trend is upward. The value that we would like to see should be in excess of 100 millimeters mercury. This is a normal patient without any pathology, and very quickly arrives at 100 millimeters of mercury. So they have already passed the test as far as the 100% oxygen 1 atmosphere challenge goes. At this point, we continue the monitoring from 5 minutes until 10 minutes have elapsed. Once the full 10 minutes have elapsed, the highest value is recorded, and that then becomes the final value of the oxygen challenge. Note that in some cases, patients who have proximal arterial disease may actually have a paradoxical decrease in the oxygen. After the test is completed, the test results are discussed with the patient, who is then advised what the implications of the test are and what the subsequent follow-up tests or interventions are likely to be.
All right, so that gives you an actual sense of what it's like to do a TCOM. We do more than one site, as I mentioned, and just also the reason why the value sometimes drops with peripheral vascular disease is you get proximal vasoconstriction. So in the normal blood vessels, in response to oxygen, they sometimes vasoconstrict, and you then get a paradoxical drop in oxygen in the distal area, and that is typically a poor prognostic sign. So what do we build into the interpretation? Obviously, there needs to be oxygen in the arteries. There's a consumptive element. The oxygen is used. There must be some circulation under the electrode, and there is this responsive vasoconstriction. And what we then do is we look at the slope, as I mentioned. Normal would look like this. You'd have a rapid rise, as you saw. If it's inflammation, the rise will be rapid because there's hyperemia, but it won't achieve the high normal level because there's overutilization of the oxygen. If there's a edematous situation, there'll be a delay because it needs to work through its way through the edema, and then it will start to increase. And of course, an arterial value will hardly rise at all. The most definitive test that we can do is doing a transcutaneous measurement in a chamber. And if the value is above 200, we pretty much are confident that it will heal, bearing in mind the appearance of the wound, of course, and other mechanical aspects, if you will. If it's below 200, we are not confident, and vascular options then are preferred. This transcutaneous oximeter is the only device of which its probe, which is an electronic piece of equipment that heats to 45 degrees centigrade, is allowed in a 100% oxygen-filled chamber. Only that in communication systems. Otherwise, it's a fire hazard. So these devices can be connected, and we have that capability here at KHMH. What are the dangers? Well, one of the problems is you can burn the skin. If you leave it in an ischemic limb for a period of more than 30 minutes at 45 degrees centigrade, you'll get a burn like this, which is my patient to my disgrace. Now, they had an ischemic limb. We were desperate to see whether we could get the oxygen up. We had them on air and then in the chamber. And in the process, at 45 degrees centigrade, we managed to produce a blister. Now, that's not the end of the world, but you clearly don't want to do that if you could avoid it. So you don't want to have the assessment for longer than 30 minutes on a single site in an ischemic limb. The bigger concern is coming to the wrong conclusion. In other words, you do an assessment, and based on the assessment, you make a major decision, for instance, to amputate or not. What we do find, though, is where the surgeons have already determined an amputation is necessary and the patients are reluctant because they just feel there isn't enough being done, what we've often found is doing a transcutaneous oximetry test where they physically can see the oxygen in their limbs is a very useful counseling tool to actually allow the patient to realize there is simply no oxygen for healing. So we actually have used that for that particular purpose. Now, the easiest way to consider the readings, the outcome of a transcutaneous oximetry assessment are 3 R's. The readings on air, that's 20% oxygen at 1 atmosphere, as you're sitting here. The ratios, which is the wound versus a reference site. And lastly, the responses, either to oxygen by mask, as you saw, or oxygen in the chamber. So you've got readings, ratios, and responses. I'm going to expand that to show that the readings, we distinguish between diabetics and non-diabetics. In diabetics, we want a higher value of 45 before we know that oxygen is not the limiting factor. If it's below 45, we need to prove that we can get it higher than that. Okay, so above 45 is good, below 45 is not good, and we need to then confirm that we can increase it to be therapeutic. In non-diabetics, that same threshold is 10 millimeters mercury lower because there aren't the other challenges to metabolism and healing potential. The ratios we use typically are reference site on the chest versus the wound, and like the ankle-brachial ratio, same principle, we compare the abnormal to the normal and come up with a percentage. And then lastly, we plot the response to 100% oxygen at 1 atmosphere, or if you like, in the chamber at 2 atmospheres, which you might think of as 200% oxygen. That's technically incorrect, but it is easier to remember. On 100% oxygen, we want 100 millimeters mercury. On 200% oxygen, we want 200 millimeters mercury. If we don't achieve them, then we need to consider other possible solutions because oxygen treatment is not necessarily going to work. So I'm going to add color, which you'll also see in the 3 cases that I'm going to do next. When it's labeled in red, it means it's a problem. When it's labeled in green, it means it's okay. It's where it should be. The reference site, as I indicated, typically on the left side of the chest, mid-clavicular line. But one of the problems that we have now that cardiac bypass surgery is so common is that the site here is affected by the internal mammary artery. And that's usually harvested as part of a cardiac bypass graft, which means the chest oxygenation is abnormal. And we then often jump to the deltoid because they can even use the right mammary artery as well. So that's just a technical thing that you need to know. Okay, so here, let's go. Technical things usually bore people, but clinical things get all the clinicians awake. So here we go. Case 1, 67-year-old female, non-insulin dependent, 27 years, developed a septic toe, had an amputation of the toe, had cellulitis and pain, and the recommendation by the orthopedic surgeon was amputate below the knee. This is what the foot looked like. I know the photograph is a bit granular. That was low DPI days. It's several decades ago. And this is what we found. So let me orient you. This is the reference site, 76. So that's on the chest of this person. They didn't have a cardiac surgery that would lower that. On the top of the foot, it was 56. And in the first web space, it was 55. Now, going back to what I showed you previously, in diabetics, we want a value above 45. So those values are green. The regional perfusion index, if it's above 80%, we consider that normal. If it's below 20%, we consider that to be non-therapeutic for hyperbarics. And in between the two, between 0.2 and 0.8, is possibly where we have a role. So that's an orange level, but we now need to see whether we can truly improve it. On oxygen, 100% oxygen at 1 atmosphere, what do we want? 100. That's more than 100, which is why we didn't need to do a chamber test, because we had already shown we can be therapeutic. Even with ward oxygen, it's achieving the level we want. So in this particular patient, we gave them 10 treatments, extensive wound care, a further follow-up 15 treatments, and they went the way through and the wound healed very well. And we did a follow-up study just to see whether the patient was now independent. And you'll see the chest value is a little bit different, but we'd consider that within the normal range. The foot values are slightly better because there's less inflammation. The regional perfusion index is improved, partially because this is less, but also because that is more. And you can see that this, which was 147, is now a little bit higher. And that's an effect of angiogenesis. You actually cause new blood vessels to grow into the area. So that's a very, very good thing. And they're not subject immediately to the problems that diabetics have. It will undergo the progressive changes from that point, but there are new blood vessels nonetheless. Now, this patient went home, was very happy, and those in the southern hemisphere will immediately know what the problem was here. She came to our clinic with this wound on the tip of her toe. And unlike Bahrain, which in July is as hot as Hades, in South Africa, it's sort of polar cold, and this lady had a hot water bottle. And she burned her foot because we had fixed the ischemia. We had fixed the infection, but we cannot and have not fixed the insensate nature of the foot. And patients need to think on behalf of their feet because they cannot feel on behalf of their feet. So that's always something we need to bear in mind. Okay, here goes another one. Let's see how you do with this. 53-year-old male, insulin dependent for 15 years, 2 myocardial infarctions, a cardiac bypass graft, now a septic toe with a ray amputation, cellulitis and pain, referred to us with a recommendation of a below-the-knee amputation, this time not only from the orthopedic surgeon, but from the vascular surgeon. And that's a very ominous sign. If a vascular surgeon refers a patient, we're usually rather concerned. So here's that wound that you've seen before with a transcutaneous blister. And look at the difference in this one. Why did we use the deltoid for the reference site? Right, because of the bypass graft. Good. This is the value on the foot on air. 2, web space 1. What do we want in a diabetic? 45. Down, okay. Regional perfusion index, we want that somewhere between 0.2 and 0.8. This is 0.018, or if you like, 0.02. So that's bad. And on 100% oxygen, and in fact, even in the chamber, this was the value on the foot, which shows you that that gas-tight seal of the electrode is a gas-tight seal. This equipment was at 2 atmospheres, 100% oxygen, and yet that electrode didn't budge. It shows you it measures the circulation, not the atmosphere. Does everybody follow what I mean by that? Okay. All right, so that's the problem. Everything is the problem. And we don't have a therapeutic option here. And therefore, this patient did undergo a below-the-knee amputation and recovered, I'm glad to say. The last case, 51-year-old, yet another diabetic, non-insulin dependent, 5 years, septic foot, multiple debridements, cellulitis and pain. Now it sounds a bit repetitive, but that's how they come, and a below-the-knee amputation recommended by the orthopedic surgeon. That's what the foot looked like. We decided, well, let's get evidence. We did a transcutaneous assessment. He didn't have a cardiac bypass, so we used the chest. 55 is a normal value. The value posterior tibial was 30, and this one was 48. So what do you think about these values? All right, well, if we use 45 as our metric, then this is low, or lower than it should be, and this is at least 45. And now you can see the importance of using more than one site, because if we'd only used this or that, we would have arrived at the wrong conclusion. Looking at those, we thought this patient does have a possible chance if we can prove that we can raise the oxygen. The regional perfusion index was also between 0.2 and 0.8, okay? And lo and behold, when we put the patient on oxygen, this nearly shot up to 300 millimeters mercury. We would have been happy with 100. So we didn't need to do an in-chamber assessment because this was already green to go. You follow? Follow the reasoning? Okay. So you got 12 treatments, split thickness skin graft, a further 10 treatments, and this is what the foot looked like a month later, a further week later, and ultimately at the end of August for this particular year. The orthopedic surgeon, which at that stage was still rather incredulous about HBO, said, well, you've healed the wound, but it's not going to stay healed because you're not giving oxygen every day while this person is working as a gardener, which was his vocation. Well, I'm happy to say this picture was taken more than a year later, and he still had both his boots on. So this person had a very, very good outcome. It was a perfect referral, actually, for HBO. So we need to make our decisions wisely. And we need to use those parameters that I showed you. The air value tells us, is it a problem or not? The ratio gives us an indication of the extent of the problem. And the response then shows us whether we can be therapeutic in our treatment. Okay? We need to bear in mind that there can be changes in central oxygenation. So we do a oxygen saturation on the patient to determine their central oxygenation state. If they have got COVID or they've got COPD and their pulse oximetry is 84, clearly the values in the limbs are also going to be low. So we need to consider that. The skin is also relevant to consider. We can't put probes on the palm or on the sole. It has to be on thin skin. We can adjust the temperature, and when you read the literature on transcutaneous oximetry, always ask what the temperature of the probe was, because for each degree centigrade, the normal value is 6 millimeters mercury of more oxygen. So in other words, let's say it's 20 at 42, it'll be 26 at 43. You follow? For each degree, the normal value will be 6 millimeters mercury higher, which is why a lot of the French literature, you'll see they say 20 millimeters mercury is fine. Why? Because they're measuring at 42, not 45. So it's a very important thing if you look at references. Okay, so in closing then, transcutaneous oximetry is an objective reflection of tissue oxygen. It really gives us the only insight in the area we want to treat. It can correlate with healing potential, tell us whether it's likely to heal or not. And we can either demonstrate hypoxia when it exists and identify it as a healing problem. We can then decide what the best intervention is. Is it vascular surgery, if that's possible, or hyperbaric oxygen, if that's possible? And we can arrive at the point, as we did with the first case, where they were now no longer dependent on hyperbaric oxygen therapy, but would go and did go on to healing without any further oxygen treatment. So I hope this isn't the way you feel at the moment with the mathematics or the values that we gave, but it's actually relatively simple. All you need to remember, air, 45 for diabetics, 35 for non-diabetics. the ratio between 20 and 80%, 100% oxygen, 100, 200% oxygen on 2 atmospheres of 100%, 200. And you have essentially got the cornerstones of transcutaneous oximetry. Okay, with that, I'll open the floor to questions, if there are any. I see there are some chats. I'm just going to unmute. So I'm just enabling that people are able to unmute. Let me just see. Okay, there are a number of things about can't hear, couldn't hear, want to hear, lovely, low volume, still low, better now, thumbs up, excellent talk. Thank you for that one. Okay, all right. Are there any other questions? Yes, Dr. Brahmana. All right, I'm going to repeat your question just for the sake of the audience. Dr. Brahmana has asked, can we use transcutaneous oximetry in children as with adults to determine whether or not they are starting to decompensate? And the answer is yes, from approximately an age of 3 months. Prior to that, the blood gas value and the transcutaneous oximetry value are comparable. So you would then use it as a reflection of a blood gas. Beyond that stage, because the skin becomes thicker and the skin becomes a variable in the case of impending cardiovascular collapse, what you will then see is that value starts to drop because the body is withdrawing circulation from the skin. We're not concerned about the skin necrosing. What we're concerned about is why is the pool of blood now centralizing? Because this patient is decompensating. So that's when one would start looking at inotropes, possibly volume supplementation, and other measures. But the answer to your question is broadly yes. Thank you for that insightful question. Any other questions? The question was which sites can be used. Traditionally, the sites at the level of the shoulder have been used. So they're midclavicular lines on the chest and the deltoid. But technically, as long as it's thin skin in an area where there's no reason to suspect abnormal circulation, it would be normal. We tend to avoid highly mobile areas for obvious reasons. So you wouldn't put it on a forearm, but it's fine on a deltoid because that won't move too much. Thank you again for another excellent question. All right, I don't see any further questions. I apologize for some of the sound challenges which weren't meant to be there. What I will do is I'll cobble this presentation together, the little bits, and it will be available on the website and on the various learning platforms. So those of you that missed something, you'll have an opportunity to catch up on it. Please don't hesitate to refer patients to us for assessment. We won't do unnecessary tests and we won't do unnecessary treatments. The transcutaneous oximeter keeps us honest, keeps us objective, and keeps you informed. Thank you very much.